Hi, I'm Piper Harris, a licensed professional counselor, and welcome to the Untangled Mind podcast. This is a show for people who want to understand why their mind works the way it does, not just how to cope with it. Drawing from neuropsychology, neurophilosophy, and data-driven CBT, we look at how anxiety and trauma shape perception, behavior, and choice, and what actually helps people change. I'm an integrative CBT therapist based in the Atlanta suburbs. Each episode is designed to teach you something concrete: how to recognize what's keeping you stuck, how to interrupt unhelpful patterns, and how to move forward with clarity and steadiness. Therapy is everywhere right now, but effective therapy is not. Last year in my Catching Flack series, I raised questions that made some people uncomfortable. I asked whether the field had drifted from measurable change into something softer, more aesthetic than effective. I questioned whether support alone had replaced skill. Those conversations didn't isolate me. They clarified something. There are other clinicians asking the same questions. One of those clinicians is my guest, Emily Ferrara, founder of Simplify Life Counseling and Coaching. Our professional dialogue grew out of shared clinical standards, shared concerns about watered-down training, and a shared belief that therapy should produce movement, not maintenance. So in this series, we're getting specific. Part 1 is simple but foundational. What is good therapy? Not likable therapy, not viral therapy, not therapy that feels validating but goes nowhere. Good therapy. We're going to talk about specialization, diagnosis, measurable outcomes, and why precision matters. We'll also outline what you should look for if you're seeking help for anxiety, depression, trauma, OCD, personality disorders, addiction, or eating disorders. This isn't about attacking the field, it's about raising the standard. If you've ever wondered why some people improve in therapy while others stay stuck, this is where we start. Well, hello, everyone, and welcome. Really excited to have Emily here. So we are going to get right into it. But Emily, I would love for you to tell everybody about you, about Simplify Life Counseling and Coaching, and really your expertise in OCD.
Thanks. I'm super stoked to be here as well. Thank you. So I started Simplify in 2011 and for many of the reasons that we're going to talk about today, and wanted to create a place that can help destigmatize therapy, but specifically for anxiety disorders. So that's kind of our main focus. We see those. We're highly specialized and trained in anxiety, panic, OCD, anything that's kind of like connected with that, and co-occurring disorders, and then refer out for the rest. So we've got a great team and just love being able to offer that. We also offer faith integration if people are wanting that. So it just depends on what their reference is or what they want, but we can offer that as well.
That's great. That's great. Well, I know we'll talk more as we go through today. So this is our first part of our series. So for all of you, you heard in the intros, Emily and I got connected via one of her colleagues on LinkedIn. And then she and I realized we had so much in common and we have a passion for the field, obviously. But we really started talking about what is this idea of what is good therapy, what is not good therapy, and how do we help those of you that are really curious about maybe where she and I differ and where we're seeing kind of this clinical drift. And we're going to hopefully give you some tools and some tips on how to find a therapist that works well for you. And again, the faith integration, I think, is huge too, because in our field, I mean, it is highly secular. So to have that faith integration, I think, is really key for a lot of people. We know that research shows that integration of faith is one of the key determinants of effectiveness of therapy. So I love that you do that too. Excuse me. So we kind of started having this conversation offline and decided, what the heck, why don't we have a conversation? So for a lot of you, I did the Catching Flack series last year. So this is great. She actually said to me, she's like, yeah, have you read that Abigail Schreier book, Bad Therapy? I'm like, oh man, that was a tough book to read. And so Today, our first part is about, what is good therapy? What does it actually look like? And we think it's important to give you the history behind psychotherapy, where it actually came from. Because I think a lot of people, and I know, Emily, you can speak to this, when they come to us, their idea of what therapy is really based on what today therapy is, but it's really not where psychotherapy started. So why don't you say kind of your idea of like what this drift is, or kind of, it used to be very specialist driven. Why
Yeah.
have we
Yeah.
gotten away from that?
I think, yeah, it used to be very specialist driven. And even in grad school, and I'm dating myself, but in the early 2000s when I was in college and then went into grad school, it was very much like pick your lane. And if you're a psychoanalyst, like that's from Freud, who we know a lot about. And so, and doing the psychoanalyst work and saying, like, if that's what you want to do, then you need to be a psychoanalyst and you get all this training. And we understand. That, and then also working with like dream theory and sexualization, like sexuality and development, and all that kind of stuff, repressed feelings, all of that. And so that's what I grew up with. And like you're
Yeah.
saying, there's been more of a shift. Um, I think that because of insurance and they're wanting to be able to see more managed care, they're wanting people to be able to see a lot of different people and see them for a short amount of time. I think that
Yeah.
that's something as well. And then we also, I think, see stuff online. We see we see like, TV shows of
Yeah.
reality TV people, and they're just like, this is the most specialized I see is like couples counselor,
Yeah.
but other than that, it's like, it's just general, and it's one therapist. Even for some of the reality shows, it's like one therapist for all of these different people. Even for couples counselors, you've got
Right.
clients, you've got people on the show that have trauma or have like attachment issues and whatever, and you're like, okay, this one person can't do
Yeah.
all of these things, and yet that's kind of how people see it.
Yeah, I agree. I love that show, by the way, Couples Therapy. Have you seen
So
that
good.
one?
So good.
Fabulous.
Yes.
She's a psychoanalyst. That's
Yeah.
what I love about
Yeah.
her, how she does it. So I find her work fascinating because she is
Hmm.
100% psychoanalyst.
Yeah.
And so that's a really great show for a lot of you. If you want to kind of get a peek behind the
Yeah.
curtain, it's a great perspective to see that particular, focus of therapy. And I
What
think
good
you're right.
like, right?
Yeah.
Like,
And I think you're right. Like when we see even there's such the reality TV or, these famous people are talking about therapy, but they're not even able to distinguish that there are actually experts out there.
right.
Kind of talking about Freud, he was kind of the grandfather, but he was the Viennese grandfather. Everybody
Mhm.
knows about Freud. I actually I'm reading a fabulous book right now that made me very angry at Freud, and I can share with that later.
Yeah.
But because his focus began with hysteria because they really didn't know what was happening. And hysteria was only women. They actually used to think that it started in their uterus. Of all the things.
Yeah.
So
Yep.
fascinating. So obviously we know then he went to the psychosexual work.
Mhm.
But really for us, I think for American psychology, that's William James. So
Mhm.
he's the father. And he actually, what was interesting about him is he's kind of one of the first cognitists before
Mhm.
Beck came on.
Mhm.
My
Mhm.
background is CBT, is that's kind of my background. But it's really interesting because we see a lot of that work. Carl Jung and Freud were in this kind of study group together, as
Mhm.
was Alfred Adler, and we never hear about him. We
Mhm.
never hear about Adler. But it was so specialist driven. I think you and I talked about too. It was much more medically driven, complex
Yeah.
presentations.
Yeah.
So if you were to play kind of along, if we're in the early
Yeah.
1850s, 1900s, and somebody came with OCD to you,
Mm.
what do you think? I mean, would you be like, this originated in your uterus? I mean, what do you
Wild.
think that would have been like?
I don't know. And my understanding was, and this is pulling from grad school, is that a lot of disorders that we know today weren't diagnosed. So they saw mostly like hysteria or people who like schizophrenia. And so even like the asylums in the 19
Yeah,
1980s, is they were um, treating the more extreme things,
yeah.
right? And so I think that it doesn't mean that, and I also will hear sometimes from parents who are like, do you think this is just a fad? Do you think that because now it's kind of like in vogue
There
to,
is some fads though with these kids,
there
like when they had the
are,
tick. Everybody had Tourette's for a while.
yeah, and
Yeah,
there's, and then, but I think it's also, if you knew that you were going to have to go to this scary asylum,
yeah,
yeah, I'm good. I'm great.
yeah,
So,
yeah,
like keep it down, shove it down. And
yeah.
so, I just think that it was much more of a medical model. It was it was very specified to the extremes. And as, you know, psychology progressed, as different theorists came out with different theories, and then also like just the decade of the brain, you know, starting with the 80s and 90s, and us understanding like what we're actually dealing with, I think it definitely helped normalize it. But as in the normalization, I think we watered down the treatment process.
Yes. Oh, that's a great way to put it. The normalization has watered down the actual clinical treatment process. And it's interesting, even talking with grad students now, I do some mentoring. I used to work in psychiatric hospitals. Those are unheard of now. I mean, and unfortunately, with the closing of psychiatric hospitals, we see this on our streets. And these are the most underserved communities. Lots of schizophrenia, lots of addiction, always that comorbidity. But it's fascinating. There's so very few psychiatric hospitals. And I remember walking those halls going, ooh, like this is you just, until you're there, you have no idea what it is. And they glamorize it on movies. And schizophrenia, for example, is just horrific. It's so awful for the individual or someone that's bipolar in a current manic episode. It's just awful. But again, kind of going back to what we're talking about, good therapy actually, we think, should be much more specialized than the watered down version we have today.
Yeah. It shouldn't just be generalist, or you have to go to inpatient, right? And somewhere along the lines, we've lost our way, you know?
Where do you think that shift, I know we have an outline, everybody, that we're kind of talking through, but where do you think that shift happened? What do you think societally or even politically, or maybe insurance driven? What happened with this drift?
I think a lot of it's insurance driven, you know, and managed care, which is helpful, but also like, I think it's also not, the consumer's not as informed. So when you think about, where you go, so much of it's, word of mouth. So for our clients, so much of it's not like Yellow Pages, or if they still even have those, you know,
nobody knows what a Yellow Page is.
You're like the mom group that went here and here. And yes, people find us from Google, you know, find you, but it's so much, it's just word of mouth, like how we met, right? Word of mouth. And if you trust the source, then you can refer out and stuff. So I think a lot of it's also not informed, kind of connectors. So think about like if you're like, hey, this is a great therapist, they worked really well with me. But sometimes who works well with me is not going to work well with you, Piper, you know? And so being able to understand like, this is a really great therapist that works with X, not Y. And so sometimes, especially as people are talking about, even influencers are like using, this is what my therapist said. Well, what kind of therapist are you using, right? And like, they're effective, you know, if you have some sort of skin disease and I go to my endocrinologist, like
it's not going to work,
right? Like it's not going to be helpful. And so it will be helpful for other things, but it won't be helpful for that. And I think a lot of times people are like, well, it worked with this person. For this person, it's like, but you also don't know what they're dealing with necessarily. They're talking about the broader scope of it, perhaps. Not necessarily.
Well, and I think too, like you said, just with the influence of social media, with influencers and all of that, is that in particular, our attention span is so much less that we're driven by these like little 30-second tidbits of psychology. And again, it's about educating the public on recognizing when there's clinical need and recognizing when you need an expert. And a generalist, I mean, we're not speaking terribly about generalists. In fact, anybody that has to go through internship has to practice as a generalist. We don't have a choice. Because a generalist does fit a certain type. But if we're really looking at what we would call clinical levels of distress, that is when you need to do your research on who's an expert in OCD, who works with trauma, who works with personality disorders. You know, it's really key, because I think what I hear a lot of times when people come to me, they're like, well, this therapist said they did 15 different things. Right? They look at their profiles on psychology today, and it's very hard for them to discern what's going on. And so I think part of what good therapy is, or that we're hoping to promote, is the education of the general public that if you really, like you just said, if you really have a need, just because Susie's therapist was great for Susie doesn't mean it's going to be great for you. And
Mm-hmm.
it doesn't mean the therapist is bad. It
Mm-hmm.
just means it's not the right fit for you. So
Mm-hmm.
I think that generalist approach is, and with this societal kind of quick little 30-second TikTok influencers and all of
Yeah.
that, has really caused a huge drift.
Yeah. Yeah. I think it's true.
So, well, we're talking kind of about the origination of psychotherapy. And I'll share this little tidbit for the listeners. I'm reading this fabulous book called Trauma and Recovery. I do not suggest it for listeners that are currently working in trauma. It's a pretty detailed book on trauma, so I don't suggest that. Interesting thing about Freud is he actually was one of the first people to study trauma. They called it hysteria. But ultimately, what he did is this is when he started listening, kind of that talk therapy started happening. And the unfortunate thing that happened with Freud is he was very much influenced by the aristocracy of the time, because he learned that it was really about sexual exploitation of women and children. That
Mm-hmm.
was histrionics, I guess you could say, that he was seeing. And rather than continue his studies, that's when he decided to shift to psychosexual
Yeah.
motivations and made it about the woman. It was very interesting. But when you read the history, I got very
Mm-hmm.
angry. Like, hey, Freud, you put us behind the ball here with trauma work. But it was a good book.
Yeah.
So,
Yeah.
but so we talk about expertise. We know that you have an expertise in OCD. I have an expertise in PTSD,
Yep.
complex PTSD. So there's a lot of different primary ways that we work with them. Why don't you talk about how people know, number one, what is OCD? And number two, what do they focus on? What would a therapist focus on, so that we can kind of educate our listeners on
Yeah.
that?
Yeah. For OCD, it's really important to make sure, and I know that both of us is what we align with, is having data-driven diagnoses.
Yeah.
So making sure that if someone comes in and is like, I'm so OCD, I know it's a phrase that a lot of people use, or like just like we do with, unfortunately, people do with bipolar or borderline or
Yes. Yeah.
panic attacks, but being able to say, okay, tell me more.
Yep.
And whatever the diagnosis is, but specifically for OCD, we'll use Y box or Psy box. It's kind of the gold standard for assessments. And within those 10, 11 questions, we've got a good read on the severity and if they have it or not. Sometimes they'll take it and we realize, oh, you are obsessing, but it's not necessarily OCD. And
Mhm.
so that could be more of social anxiety or panic disorders or whatnot. So the Y box is really helpful in us being able to pinpoint what type of severity we're looking at.
Yep.
And then also, I think looking for someone who takes those assessments seriously and is able to use them throughout the therapeutic process to make sure engaged, like, are you progressing in this process? Another major thing to look for is ERP, which is exposure response prevention. That's
Yeah.
also gold standard. So if you have OCD and you're not exposing yourself, if you're not having to do exercises in counseling, outside of counseling, if there's not like a heavy amount of homework and action items, that would cause me to have a big red flag with
Okay.
yeah.
So that's good. I actually didn't know that. So there is a pretty large psychoeducational component to OCD
Yes.
treatment, is what I'm
Yes.
hearing you say.
Yeah.
Okay.
Yeah. So, and really helping them, I think the biggest, um, sometimes the biggest challenge is it's getting them to recognize that they have OCD. Some people come
Yeah.
in and they're informed. We see two different types. We see people who have been informed, but they've had bad therapy. I think
Yeah.
well-meaning therapists, right? Like we don't want to bash our own community, but like they're people who are well-meaning and saying, okay, I work with general anxiety, so therefore I can work with OCD.
So
And
different.
right. And so they'll talk just like with trauma, right? Like we know that talking about it for OCD and for trauma can
Yeah.
just cause increased distress and can actually make it worse. And
Yeah.
so a lot of times them talking about it, we know that that's not helpful on its own. And
Yeah.
so, or trying to give reassurances. And so the therapists actually are engaging in the rituals themselves and giving reassurances. And they do
Yeah.
need So we've got people who have gone to other therapists and are like, they're really nice, like they're kind. I feel like I'm getting coffee with a friend. And I'm like, but
Yeah.
I'm not feeling this is challenging, and I'm not getting better. Or people who just think they have general anxiety or something's a little off, and then we go through it and they say, okay, maybe they're in their 20s or 30s, and we realize that this has been something they've done, like little, if they're like little quirks or whatever that they've seen as quirks, they're really rituals. For their
Yeah.
entire but yeah.
So with that, how do you distinguish between OCD? I mean, we've got obsessions and compulsions because that's the big. And so everybody, obsession and compulsion. Obsession is thought, compulsion is action. Is that a good way for them to understand?
Yeah, it can also be thought. So the compulsions could also be internal. So it could be mining for information, going through something over and over again in your head. So sometimes that's the tricky part too, and that's why the assessments are so important
Yeah.
because it can flag, you know, is this just a worry, or are you doing something to help you not to release the anxiety that you experience from the obsession?
Okay. So
So
then how do you distinguish between that and OCD PD or personality disorder, like more that perfectionism kind of
mhm.
thought process?
I um I'm gonna I think I've had like one OCPD. So with that, and it her life was like just upside down. Like it was
Yeah.
very it was really hard for her to engage in the process too. Like
Yeah.
she couldn't, well, I probably shouldn't even say this in a,
Yeah.
yeah. Anyway.
Well, in OCD PD, what I see it over here in this practice is it comes up very much like, and again, this is what's the hard thing for everybody that's listening. Do I have OCD or is this like severe generalized anxiety? And so the
Hmm.
OCD PD, I see that more of like that real perfectionist mindset, the
Hmm.
type A, like really type A kind of
Yeah.
person.
Yeah.
And that is the hard thing. And I think that's where we have to educate the public on good therapy. Generalist therapy is helpful for some, but if you again are having these issues over and over and over again, that's
Hmm.
when part of it too is, as a listener, your job is to do the research.
Hmm.
And I think that's part of it too, is we're used to just, well, a therapist does everything. A therapist
Right.
shouldn't do everything.
Right.
That's
Right.
not healthy for you.
Right.
And so part of
Right.
your job is to don't go Dr. Google too long, because we
Right.
know that's not good.
Yeah.
But to educate yourself on, gosh, what could this be, what's going on, and
Mhm.
interview therapists. It's okay for you
100%.
to interview a therapist. And if they're very generalized in what they say, go to the next one.
Yeah.
It's
Yeah.
okay.
Yeah.
It's fine. I
Yeah.
think too, one thing that you just mentioned was talk therapy.
Hmm.
Everybody talks about talk therapy. First of all, therapy is talk.
Right.
We don't
Right.
do it through osmosis.
Right. Right.
But I think that might be what we're talking about, especially between what you and I do. You do ERP, and
Hmm.
I do exposure therapy too. I mean,
Hmm.
ERP is a
Hmm.
form of exposure therapy, EMDR, prolonged exposure. It's the whole thing. And the
Hmm.
whole premise for everybody that's listening to this, the whole premise is exposures. We have to expose the person's brain to the very thing that's causing
Hmm.
that fear response, and then obviously all of those compulsions for you, obsession, whatever may happen. We have to expose that brain to that thing. um and so I think that's the difference too. When we look at these really particular needs, clinical needs, exposure is a really important part.
Huge. Huge.
Mm-hmm.
Yeah.
Mm-hmm.
And you have to just do it, like
Yeah.
just do it, the Nike
Yeah.
phrase. And some people just stay kind of just circling around the issues
Yep.
and they don't feel better. And that's where, then people can leave with bad taste in their mouth saying therapy didn't work
Yeah.
for me, and it's like, man, that was such a miss and loss on
Yeah.
our end.
Yeah. And listen, anybody that's listening to that, exposure therapy sucks. We're just going to say it. I mean, it's not fun. It
Yep.
is highly, highly effective. It is backed by research. I
Hmm.
mean, the exposure work, that ERP,
Hmm.
prolonged exposure, EMDR, those are some first line treatments
Yeah.
for these sort of issues that people might be dealing with. Same with panic disorder, generalized anxiety disorder, social anxiety disorder. Exposure is 100% has got to be the part of your treatment, no matter what. Because again, you're going to circle that drain, and then you're going to say therapy is, or that therapist sucked, or the therapy doesn't work for me. And really, it's just you were missing a really core component,
Right.
of that type of therapy.
Yeah.
So that's helpful, I think, for the OCD. Also, it was, you said, we've talked about that it's really about tolerating uncertainty.
Yeah, yeah. It's these like unwanted intrusive thoughts that are one other differentiator is the ego dystonic. So they go against someone's values. And that's why it's so um, that I usually see like highly virtuous people, very altruistic. And so usually the obsession is a threat to something they value immensely.
Yeah.
So it's so dysregulating because it's they're like, I would hate to hurt someone's feelings, or I would hate to harm ones, or relationship ones, any of that kind of stuff. So it's and those are the components that are for it. And I think it's challenging because just general anxiety is like just realistic concerns. Oftentimes for the OCD, it's like it's imaginative, it's magical, even the person knows that it's not realistic, but can't separate themselves from it. And it focuses so much on trying to prevent, like it's avoidance based, which you see with trauma, right? Like I just want to avoid this. And so some people, they'll come into therapy, and if it's not ERP, they'll actually feel a little bit better as they talk about it because they're talking about it's like they check the box, but their avoidance is still really high. And so they're not having to do the work. And so it's like, yeah, maybe their Y box is actually is lower than it should be because they've done such a good job of like surviving in this space, to where they're not facing it, but their life is very much, it's very limited.
Yeah. Well, and I think that's a good thing to kind of pause and say to everybody is that when you're a clinician, if you're really choosing to focus on data-driven work, understanding what your primary population is that a core component that we see with all of these individuals is that talk therapy releases the valve just a little bit. But there's always an avoidance component. And then inevitably what comes along with it is shame. Shame is a huge driver for a lot of these things. And that is why that exposure component is so key, because it does help them expose even to the shame-based stuff. I mean, we all feel better when we speak out. I always say to people, and I think it's from AA, that the secret is our sickness. Secrets are our sickness. And so that's why talk therapy can feel good for a little bit, but you're missing that component to really work through. Do you find too, when it comes to this kind of drift from a specialist driven approach, that a lot of it is that they've gotten away from psychotherapy homework?
Yeah. And sometimes they'll I think that it also, as therapists, it's hard. I equate it when I talk with people about it. And once they get the buy-in, first I have to get them to recognize that this is what you have, and assess and help them with motivation, increasing motivation, right? But then once they're doing it, it's like, okay, it's uncomfortable. As therapists, I equate it to, I had back surgery years ago, and I remember within hours, I had a PT come into the hospital room saying, okay, we're going to get up, like we're going to start walking.
You'll walk.
No, I say that in this realm, we're more like PTs, we are helping you have more freedom, right? And yet we have to face it. And I'd imagine it's similar for you with trauma of like, people have done such a good job of protecting themselves from the discomfort that we have to, I say, like, it gets worse before it gets better. Just so that they can understand, like, yes, it's going to be uncomfortable in this session. Not only is there shame after the first one, which, by the way, one research article showed that 1 in 3 adults don't come back for a second session. And I think a big parts of it is because of that, right?
Yeah,
So they have
absolutely.
they have the shame, and then it's the discomfort of it. And so our job is to use our skills, our knowledge, and continue to build that rapport. So we're able to say, like, hey, it's worth it. It's worth
Yeah.
it on the other side.
Yeah. Yeah. And that is definitely it. I think psychoeducation can also be done in the rapport building in the session. It doesn't mean that, I mean, I wrote a notebook, a workbook, but they don't have to do that every single
Right,
session.
right,
But
right.
education, I think, is a real key differentiator to good therapy.
Mm-hmm, mm-hmm.
Because often I think what we're seeing too with the generalist approach being more out there now is universities. Like
Mm,
they have to cover all of these
totally.
components for licensure standards, but nothing is niched down. Like it's
Yeah.
all my mentees say, am I going to be ready? I'm like, no, not at all. Like
Yes, yeah.
you're going to have to figure this out. And so the clinician
Mhm.
needs to educate themselves so that they can educate, because I think that's a huge part too with what
Yeah,
our work, even when we come to personality disorders, is
yeah.
educating the person. Because, trauma and borderline, they're like this.
So close. Hmm.
And but we have to be educated enough to educate them, and that decreases shame, because we're like, this is what it is. There's
Totally.
no shame. We know you don't like the thoughts that you're having. We know you don't like the behaviors you're having, but I hold no shame for this. This is what's happening. This is what's happening. This is what's happening.
Hmm.
That's why education, it takes the person out of participating with the shame to stepping out of it and observing the shame and saying, but this is what's taking actual place.
And I think that's where having such experience in something is so helpful. They know the difference when someone's the first client versus someone who's been doing this for a long time, and someone who
Yeah.
specializes and goes into it. And you can also, I will not give names and stuff, but I'll say, many times, and I'm sure it's this way for you, people are like, okay, but am I going to get better? Right. Like for
Yeah.
everything, it doesn't fully go away. We're symptom management and it reduces significantly, but I'm able to say, hey, here's this, here's this, here's this. And they're able to hear, you're not going to stump me. Right. Like we're going to
Yeah.
collaborate together. We're linking arms together and we're going to work together. And there have been some wonderful, and there are wonderful stories that we can hold
Oh,
to.
of course.
Yeah,
Yeah.
it's okay. Or like one study said, it's like, no, you're able to pull from your own experience for sure.
Well, and I wonder if that's part of what we're running into too, is the idea, the general public, the idea of you're going to fix me,
Yeah.
right? Like we have a
Yes.
magic wand.
Yes. Yes.
and and it's really not, it's like it's symptom management. And I always tell my clients, you can't take away your trauma, and I
Hmm.
don't want you to take away your anxiety, because anxiety is good. It's just a
Hmm.
matter of how high it is,
Hmm.
right?
Hmm. Hmm.
And it is symptomatic, but there's no us fixing you.
Right.
It's
Right.
participation together.
Correct.
Yeah.
Correct. And
Yeah.
that's where yeah, it's hard because when people sometimes they'll think, okay, you're fixing me, or it's almost like going to the spa. Like I
Yes.
just love coming, and I'm like, for certain disorders, it's really hard at
Yeah.
first. And I hate even saying that because I don't want that to turn people off from wanting to do the
Right.
work with their trauma or their OCD. But man, the freedom on the other side, right?
Yeah.
Like it's being able to
Yep.
say, we're gonna like, we don't want to just, change this sofa. We want to totally do a whole reno so that you
Yep.
have so much more freedom because we are dynamic people, right? Either we're getting worse or we're getting better. So it's not
Yeah.
like you stay here and you can just stay comfortable. It's like, no, you're either like cuddling with your porcupine and you're going to bleed
Yeah.
out and get worse, or you're making those changes to get better. And
Yeah.
but I think our field has done a disservice in saying, hey, let's just talk about it
Yeah.
as if
Yeah.
it's like this like conveyor belt process. And it's like,
Yes. Yeah,
that's not how it's
and
done.
it's doing nothing. And I
Yeah.
think too, talking about more the generalist versus specialized, I think in particular too, what needs to be noted is a couple different things. If you are currently in addiction, alcohol, drugs, sex, gambling, that
Mhm.
sort of thing, you need to take care of that and find a specialist in those areas. Or in conjunction with a specialist, a drug and alcohol expert, or whatever it may be, as well as another therapist, because the brain cannot do this hard work until it's sober from
Mhm.
that addiction.
Mhm. Mhm. Mhm.
And so people need to understand that. And I tell my clients, if I'm seeing that they're actively abusing drugs and alcohol, I can't, you need a sober brain, and I won't step into the really tough stuff until that happens because I don't want to hurt you. And I'm
Mm-hmm.
very open about that. That is a dangerous process for me to put you through exposure therapy if you don't have a sober brain. It's really important that people understand, and we understand there's rarely a what we call a pure diagnosis.
Mm-hmm.
Rarely.
Yeah.
It's
Yeah.
OCD and it's
Yeah.
trauma
Yeah.
and so we have to kind of chunk those diagnoses down so people know that's how someone builds an effective treatment plan.
Mm-hmm. Mm-hmm.
Is it's okay, OCD, we got to tackle this first, and usually it generalizes to everything else. But
Mm-hmm.
if we've got an active addiction, we have to tackle that first before we can do the rest of it. Because what is addiction? Addiction is just the soothing for the very thing that they need help with.
Right, right. And I think it's interesting, Piper, I think we need to also, as clinicians, embrace referrals out to
Yes.
experts, right? Like, and I think that in school you're taught all these things. I felt like I was drinking out of a fire hydrant, and then help treat the person. And in some ways, there's some schools of thought that say, okay, you need to stay with that person because they built rapport and you don't have
Yeah.
abandonment. And so I think that we can actually reframe that and say, you're actually showing them what ethical care looks like when you say,
Yes.
I'm still here for if time, finances, whatever, if you need to see somebody else and then come back, like to work on the addiction and come back, or if,
Yes.
if that is, especially if they've had any kind of attachment issues, it's like that actually shows them a healthy level of attachment of
Yeah.
it's this is about you being able to be released into the world
Yeah.
autonomously, and it's not all dependent on us. But I think some therapists
Oh,
feel bad, not
I
just
feel bad still. I
yeah.
mean, I still feel bad having to say to a client, we have to stop here. I can't
Mhm.
ethically continue to treat you until we
Yeah.
knock this thing out. And it you do
Hard.
feel terrible. And then we have to hold the line, the boundary, knowing that there's attachment. We know there's attachment
Yeah.
fractures in their
Yeah.
history, but
Yes.
we have to hold that line of we can't treat you.
Yeah.
It's not ethical. It's not I can't. I will cause you harm. And I think in the moment those clients are so hurt and they're thinking in their minds, but you're causing harm right now.
Right.
And it's kind of like with our kids,
Yeah.
right? It's, you know, you feel like I'm causing you harm by making you go put your nose in the corner.
Right. 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 Or jumping
But
in the
it's
pool and swimming, and yeah, all of it.
yes, it's like, but we
Yeah.
have to do those things. And boy, that's a hard thing to refer out. And I think too, if you are going and you are interviewing therapists
Mhm.
and you say, I'm just not quite sure if this is a good fit, do you have a referral?
Yeah. That's
If
huge.
they get butt hurt,
Yeah. Yes.
that is a clear
Yeah.
indication that this individual is not working in a clinical lens, I don't think.
Mm-hmm.
I
Mm-hmm.
mean, if you're afraid of referring out, then there's no scarcity of clients.
Yeah.
There's no
Yeah.
scarcity. But
Yeah.
if you have a clinician that says that to you, I would say that that's a definitely red flag.
Mm-hmm. Mm-hmm.
Yeah.
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 Um, that's good. And you
Yeah.
need to be able to, I will also sometimes say, because with OCD, sometimes it's OCD and I'm needing to do this other stuff. And so we'll say, let's focus on the OCD, or like you're saying with addiction.
Mhm.
And sometimes then we'll say like, I'll say, hey, I'm here for check-ins.
Yeah.
And so that can actually help like stabilize it but help them see like, oftentimes I'll put it out there and then they'll cancel and realize like, I actually don't need it, but it's a good just reminder, like I'm here for a check-in
Yeah.
and you can come back to me after you finish X, but
Yeah.
that's, I think it's so much about the patient and what's there to help them, not
Yeah.
us.
Yeah. Um, how do you handle that brings up as we're talking about that? Client graduation.
Yeah,
That's a toughie.
it, it is. I think we start it from the beginning, even on the intake call, right? And I would imagine you do too, is being able to talk about leaving from the
Yeah.
beginning, right?
Yeah.
That we say we're doing a good job when we're out of a job, um,
Yes.
right? Like
Yep.
the goal. Now, there's some people who stay for longer levels of
Mhm.
treatment. There are some clients that need that like steady presence,
Mhm.
and but even with that, it's not every week, right? It's
Yeah.
because
once a month, once a
right.
quarter.
Right,
Yeah.
right, right. It's the check-ins and stuff. And so
Yeah.
and that's normalized so that our clients are like, hey, I haven't seen you in a while. And it's like, that means it's great. How's it going?
Yeah.
And it's not this like, I haven't been to confession in how many weeks. It's like, no,
Yes.
it's not that. But yeah, I think it's being able to talk about like my job, like it's not about us, right? Like I
Yeah.
think
Nope.
we're like balcony people. We are able to give them tools, cheer them on as
Yeah.
they're like on the stage of life, and then being able to kind of work ourselves out and say, hey, in the perfect, like in healthy community, we link
Mhm.
our arms with you, and then we connect you with other people who can be just healthy, grounded sounding boards and
Yeah.
resources and all that kind of stuff. Even with the work that I give, and I'm like, and I love how you've got print materials and electronic materials where you can say, hey, here, get this, but it's not dependent on us, right? Like if we
Yes.
walk off the face of the earth, it's not like, oh my gosh, it was Piper, and I
Yeah.
can't survive without that. It's being able to say, like, here's the tools, use this, here's a blueprint for the future too. If you
Yeah.
move state, country, whatever, like it's not dependent on, well, this was the person and I
Yeah.
have to be this person.
Yeah. And it's hard. I mean, I think as clinicians too, I mean, we do love our work and we care deeply for our
Yes.
clients.
Yes.
And it's even hard for us to say, gosh, you know what? You're doing great.
Yeah.
You
Yeah.
don't need me every
Yeah.
week. You don't need me every 2 weeks. You don't need me every month. You don't need me every quarter. Hey, by the way, you're doing awesome. You
Yeah.
don't
Yeah.
need me.
Yeah. How
And
has that worked for
that's
you?
hard.
I'm curious. I have to do
Well,
it. Like, I see we have to bring it up like several sessions in advance, right? Because I think if you say it at that session, they're like, what is happening, right? Like that is definitely can create an attachment wound. But I'm
yeah.
curious for you, what do you
I talk about it at intake and,
mm,
for the good faith estimate, I
yeah.
actually based on severity banding, like you do with OCD, how severe are you looking at? I look at trauma levels. And I really do say this is the system I use. This is how many sessions I think it's going to take. And I'm constantly every month saying this is what your scores are showing. This is what we've hit on all your goals. And
Hmm.
so it's every month. I'm like, okay, this is where we're at. What do we need to reassess? How do you
Hmm.
feel about these things? So it's from the get go, from
Hmm.
the very get go. And
Hmm.
I think it's hard for some clients where I'm like, hey, it's time to graduate. And they're like, nope. And they dig in. And I'm like, then that's when I have to be kind of like the stern one where I'm like, I'm sorry. Like,
Yeah.
I can't because I don't want the dependence to be like, it's not about me.
Right. Right. Right.
And if my relationship with you is stymieing you going out in the community and building relationship, that is not good. I
Hmm.
can't be your savior.
Hmm.
You be your savior.
Yeah. Yeah.
That
Yeah.
I don't want to. So it's hard.
Yeah.
And I grow attachment to my clients too. I mean, I'm sure you
Yeah.
have clients, you're like, gosh, I wonder. I mean, we can be making our eggs in the morning. We think
Yeah.
about someone from 5 years ago, like,
Yeah.
oh, I wonder how they're doing today.
Yeah. Yeah.
Yeah.
Absolutely. I think
Yeah.
we can be a corrective emotional experience for them and how they
Yep.
see relationships too, because even, um, it's, I think most people are seasonal in life
Yep.
anyway, and so being able to say like, hey, we were here for a season and you did really beautiful work. You were so
Yeah.
courageous. And I applaud you for that. I also applaud your ability to reach back out if you need it in the future or
Yes.
to find somebody else if it's something that's a different component, different specializations, but like you
Yeah.
can trust yourself.
Yeah. And I think it's that empowerment and autonomy. I think that's a core component. If you really want a good clinician,
Mhm.
that's what they talk about,
Yeah.
that it really is that autonomy factor. We know in the beginning you're going to need more of us. We recognize that, but we want to give you all of the field. Like we
Mhm.
keep you in your little
Mhm.
sandbox for a little
Yeah.
bit and then we
Yeah.
slowly work outside of it.
Yeah.
That's a core component, I think, of a really qualified non-generalist therapist is like the whole point of this is to work myself out of a job.
Which I think Piper is so interesting because we've gone from, oh my gosh, they're going to therapy, like what's
Yeah.
wrong with them? Or like a kid goes to therapy and not a kid, like college student or
Right.
whatever. And the parents are like, oh, what do we do to screw up? That used to be, and sometimes in some areas, culturally is still the stigma.
Yeah.
But with BetterHelp or some of
Yeah.
those resources, it's I think prolonged treatment extensively, right? Because it's like, well, you can even the frequency that they can use it or the access
Yeah.
to it of I'm going to text therapist with, like I'm going to connect with this person over text, over video, and
Yeah.
I'm, I've heard people are like, I do it as I'm on the subway, and I'm like, what? Like, how are you able to really bring your full self
Focus.
and focus and all that kind of stuff? I feel like that'd be really hard for me as a therapist to be
Yep.
like,
Yep.
is this your stop? Like, I'm sorry, I can't focus until that. But I think it's challenging because I think that just creates this I don't know, just it creates a lack of one consistency of care, but also being able to empower them.
Yeah.
We're with you everywhere. You don't have to let us
Well,
go.
and I think, like you said earlier, it's a therapy has become an aesthetic. It's like
Mm,
going to the spa. Oh, I have my therapist today. It's like, oh, I went and got a facial every week. I
right.
mean, it's kind of turned into therapy as an aesthetic.
Hmm.
And that is not, and that's again, that's part of this drift where we're saying we really need to get to a more specialized approach because it's being used inappropriately.
Yeah.
And I think a lot of it, I would venture to say, the people, I actually just turned away a gal this week because it's like, you're doing great.
Yeah.
Like you
Yeah.
don't need me,
Yes.
and
Yeah.
she thanked me and said, nobody's told me I didn't need therapy. I'm like,
Mm,
you're good. And I think we need, because it's so aesthetically driven in society now, it's actually that empowerment saying you don't actually need therapy, you need community.
yeah.
And that's where we inform them, even books, like here's some books, here's some podcasts, get involved with a community group, get involved in your church, whatever it is, because what they're really needing is
Hmm.
community, not us.
At that level, right? I think, and that's
Yeah.
where we have this like over pathologizing, where, and I know you've talked about this, where
Yeah.
there's a difference between like a panic attack and just I got really
Really
overstimulated,
upset.
right? Like I got really anxious, or I'm very particular versus I'm OCD,
Yeah.
and I saw one resource that we give to our patients is saying, example, they're like, it's like saying I'm sick and I have cancer. It's like
Yes,
these
it is.
differences.
Yes.
And so, and for mental health, because people don't understand that there's diagnostic criteria, there are assessments that we use. We are not just like shooting from the hip here. Like if you have a clinical anxiety disorder, you hit a certain criteria for that, and we can be able to use, best practices, gold standards,
Yeah.
all help you feel better, and we can be able to mark the progress along the way. But I think a lot of times people will Google what they have. Sometimes I've even heard people call, and I'm sure you have too, where I'm like, are you reading the DSM right now? And they're like, well, yeah, like they memorized it or they're reading it on the
Yes.
and so it's yeah, I think some people have a hard time because they're like, I don't want to leave because what if my anxiety revs up, and I'm like, well, that's just worry.
Yeah.
That makes sense, right? Like that is
Words matter, right? Words matter, and the
totally,
usage of words. And that's what's happened in society too. This drift is stealing actual psychological terminology. And like you said, the gold standards, we have diagnostic criteria and they just flippantly say it.
yeah,
Years ago, I'll never forget, I don't know, it was one of my son's friends or something,
yeah,
said something like, I'm so bipolar. And I'm telling you, I whipped around so
yeah,
fast
yeah,
and
yeah,
jumped on this kid. I'm like, hold on, buddy. And explained, like, number one, when we use these words like I have OCD, or I'm so OCD, or I'm so
mhm,
bipolar,
mhm.
when you flippantly use these terms, you are, number one, demoralizing to every person that's walking around with it.
Totally, totally,
You're
yeah,
taking away the pain that they have and you're making fun of it.
hmm,
Like
hmm,
it's just, and that, I think that's an important thing too, is as the clinicians, we're not here to diagnose you with every single thing.
right,
That we don't
right,
want to do that either.
right.
But we have to be careful with our language.
Mhm.
We have to be so careful with our language. And again, if there's a therapist on your TikTok and they're kind of flippantly saying these things because they're trying to get clicks,
Yeah, yeah,
red flag.
right, 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 yeah,
Be
yeah,
careful with this one. Be careful with
yeah.
this one. So let's kind of shift to why you and I think good therapy really is dependent on, standardized care, data, to be more effective. I think we talked about like the frequency of misdiagnosis
Yeah, yeah,
is
profound.
terrible.
Yep.
Terrible. Can you speak to that, especially in particular, like maybe with what you've seen in your practice, whether it's like, I don't know if you see particularly like bipolar and OCD or comorbidity, or where do you see some of this misdiagnosis happening?
We have seen people come in with bipolar, and we, through the process, figured out as bipolar, and we're able to recommend them to a different specialist. But we see people who have they believe that they have depression, and so and they will even score high on like the BDI-2, which is a depression assessment. But the challenge there is then sometimes the doctors, if it's just a PCP, the patient's going saying I have depression, so they're getting antidepressants that are not going to help. They can actually worsen that person's case. And so research shows that it's about like 60-70% misdiagnosed for bipolar. And I believe, I can't remember off the top of my head, but I want to say it's like 6-7 years that
they get a proper diagnosis.
Yeah. And so people have been going and man, it sucks enough to be depressed and feel out of control with your emotions, but then being able to going back and forth and being like, okay, why is this not working? That's where, if you have a specialist specifically right with bipolar, is being able to see, yes, CBT is incredibly helpful, cognitive behavioral therapy, but also doing DBT and helping them. We explain like CBT is like a house, CBT is the first floor and DBT is the basement, right? So like if I'm working with someone and we're doing a lot of cognitive behavioral therapy, but they're not able to just like regulate and they have like low insight on how they're feeling, it's really hard. I'll see like, hey, wait, you're not doing your homework, or it's not that they don't want to, they don't have that ego strength to do that. And so I think that unfortunately people will continue to go and they're like, this therapist didn't work for me. Well, they didn't know what they were dealing with. And if you have a therapist who's very informed diagnostically, they're able to say, hey, I'm not your person. We need to go. Right. What are your thoughts on that?
Well, I think too, a key indicator of a good therapist is saying, I'm not your therapist. I don't, I tell my clients all the time, or even people that have called in for consults, and I find it's legitimate, like major depression, or it's bipolar. And I always say to them, I am your worst choice.
Yeah.
And they'll go, what? I thought every therapist did everything. I'm like, no, I suck at working with depression.
Yeah.
I know that. Like clinical levels of depression. I'm an anxious person. That's why I work in trauma and anxiety. Work through this. Let's, and so, but I can say that, and they giggle every time. They're like, why? I've never heard a therapist say they suck at treating something. I'm like, well, it's true. Totally. So we need to stay in our lane and know where we effectively work. And again, it's back to having a referral base is essential for, if you want a good clinician, they are going to have referrals for depression. They're going to have referrals for psychiatric medication management. By the way, I am not a fan of PCPs and medication management because they don't have the schooling. They don't have the bandwidth. Please seek actual psychiatric medication management, period. But we're going to have those. Heck, we're going to have referrals for your windows getting changed out. I mean, like, that's a good clinician is that we're trying to find referrals. I loved finding you and your practice, because I thought, oh my gosh, finally, I have someone for this. I have someone for this. A referral network is key, because God forbid that we're part of the reason they're getting the incorrect diagnosis and care for 7 years. That's heart. It just hurts my heart thinking about that.
Right. They need to know that they need to be confident. Like if they already, especially for someone with severe depression, it can be an Olympic sport just getting out of bed in the morning, so like they need to know that once they do get out of bed, the person that's walking with them is qualified and that there's hope,
Well, and I think that kind of talks about symptoms. A word that we use a lot in our profession is functional impairment. Kind of going back to, there's a difference between I'm so OCD and I'm worrying about something, or I'm so bipolar and like you cannot get out of bed. We assess as clinicians, it's not just what you say. We assess, the whole thing, including functional impairment. What that means is, how is this affecting home? How is this affecting work? How is it affecting hygiene, eating? I mean, we look at functional impairment because that is a clue, and it helps us target interventions. When we have a generalist approach, they're like, okay, they said they're anxious. We don't know how severe it is. We don't know what to target.
Right.
And you're not looking at what, and here's the thing too, OCD, anxiety, trauma, it has a function and a purpose in that person's life. If you don't identify what that function is, albeit it's not a good function right now, we call it maladaptive. But if you don't identify what that function is, you're not going to treat the right thing. And that's, again, that's that generalist talking approach.
You
know, so we talked a little bit about, we touched on that book by Abigail Schreier, Bad Therapy. And if nobody's read it, it's a doozy. I mean,
it'll scare you.
It was hard to read.
Yeah.
It was hard to read. And Abigail Schreier, she's actually a journalist. And so, and she's really kind of gone after the field, which I'm okay with. I mean, I think that if all we do is read the things that make us feel good, we're going to miss it. And so that's why I forced myself to read the whole book. But she had some really good critiques in her book. So if anybody's not read Bad Therapy, it is good. And what I'll say is, if a therapist just outright says, I'm throwing it away, then again, these are some ideas to kind of listen to. We should all be willing to be criticized. All of us. I mean, that's how we grow. So some of the things that she talked about, let's talk about some of her critiques and kind of discuss those. We've talked a little bit about the over pathologizing normal distress. This is all the time.
Yes. Yeah. And also, I did a presentation this week, using an old clip from Dr. Kelly McGonigal. I don't know if you know. But she has great work on reframing anxiety and saying, hey, it's actually not anxiety that's the problem. It's how we respond to it. And it's our response that actually can create more maladaptive coping mechanisms. It causes us to, I mean, even research showing that your life expectancy can decrease, not because of anxiety, but how you see it, because how you see it is how you deal with it or don't. And so for us, just noticing, and even I tell clients with anxiety, I have anxiety, like you were saying, you've got it. I tell people it's my superpower. Like it is right? Like it's, it helps me hustle and do well in school. It helps me do well in presentations. It helps me to focus and synthesize thoughts. And so being able to, instead of being scared of emotions, like it's realize them and say, oh, hey, it's there. And it's there because you care about this thing. You know, I would be, like you said, we've said before, like I'd be concerned if you weren't a little bit on edge, like that's body getting excited and your adrenaline running. So I think us being able to like normalize and even celebrate, just regular emotions and say like, congratulations, you're human, you know, and let's not pathologize this. Let's just say, what is even like their awareness and increased insight? What is your body trying to say to you? And how can we learn from that instead of, okay, we're just going to stamp a label on it, get some meds, you know, and get worse.
Well, and that's such a good point. I think it's like people think that they'll come to us when we'll fix them, or I'm going to go pop a pill and it's going to go away.
Right.
And again, really what this is about, and I say this to my clients all the time. I said, you know why you're here? And like, why? I'm here to feel better. I said, no, you're learning how to suffer well. Because that's this life. I mean, and that's, again, these are uncomfortable emotions, but we're going to give you the tools to manage them. You know, I was telling a client the other day, your emotion lasts 60 to 90 seconds. That's it. It's what you think of the emotion that leads to that. Oh, you know, I mean, that. And so we have to give them the tools. But again, there's anxiety that's good anxiety. It's why we're successful. And then there's the really distressful anxiety that is impacting functional impact of your life. And in maybe to our listeners, assess yourself. Is this functionally impacting your life? meaning we get you're upset and you're feeling a little distressed, but overall, what's it costing you? Functional impact, what's the cost? That's going to determine, hey, I need help, or maybe I'm kind of pathologizing my distress a little bit.
Yeah. Like we with OCD treatment, we talk about 3 chairs, and it's like, okay, you're in this chair, which is kind of fun to do virtual because you're like, now we're going to get up and we're going to move again. They're like, I get the concept. I'm like, nope, I want you to get up, but being able to say, if you're in this chair and then here's the chair next to you of what, 6 months and then 12 months, if you don't get better, what's life going to look like? And we go through the functional components, what's your health, what's your relationships, your job, all that kind of stuff. And they recognize it deteriorates, right? But like when it's just normal emotions, it comes up and it goes back down, right? Like we're able to self-regulate. And so I think it's being able to help them see this isn't something that's going to cause deterioration and, chaos. It's just, this is situational and it's appropriate. And it's even developmentally appropriate, right? For like teenagers or young adults, like having, I wrote my dissertation on the quarter life crisis because that was like such a big thing during then. And I'm like, this is normal. Like, this is really normal. We've put a terminology on it, which I think actually helps maybe normalize or call it out. But it's not a necessary diagnosis. But I think being able to see this is really normal. And it doesn't mean, it doesn't mean that you're severely depressed. It means it's really hard when all of your best friends live on the same hall. And you have like ample access to hang out with friends and time. And then you move to maybe living in the basement of your parents' house or having to hustle and working a 9-to-5 where you're just making copies.
That's a huge shift. That's huge.
That's not depression. That's like, that's
overwhelm. It is appropriate. Yeah. And I think that's the fun part too. I had a college student last month and I said, listen, has anybody told you don't need therapy? That life just is really lifing and you're learning to life. And they looked at me like, oh, and guess what? They never showed up again. They just needed the permission to understand life is lifing right now. It's distressing. Piper gave me tools. I'm going to use them, but I actually don't need a therapist for this. This is just a really hard place that I'm in because this person was graduating. Like no wonder you're feeling this way. You recognize everything is changing in just a few short months.
And that's overwhelm. And that's just short, the therapist should not be like, okay, we're going to be in this for long. It's like, hey, let's talk through what your fears are. Let's talk about where you want to head. It's almost not coaching, but it's more of like,
kind of is though. It's coaching them through it. It kind of is. What do you say to about people that over identify with the diagnosis? Because diagnosis actually can be very life-giving to some people. But what do we do with the people that's like their identity? That's a toughie.
Sometimes you can notice that beforehand because they're the ones who might be like, I'm so this, and so when that happens, I can be a little bit cautious. When it's kids, and we work a lot with pediatrics, when it's kids, I really try not to use a diagnosis before I've talked to the parents because I don't want that to be weaponized. I don't want there to be misunderstanding. I want to be able to really talk with the adult and help them understand so then they can have conversations about it. Because if someone says you traumatized me because of X, the parents, and it just muddies the water and it's not as helpful. So before I even go into a diagnosis, and that's where we do the assessments beforehand, right? As they're coming in, our intake form is about 50 pages. I think yours is pretty extensive.
Mine's pretty, it's a big one.
We want to make sure we understand and can almost like get a diagnosis just from some of the paperwork and self-report. But as we're looking through it, I will tell them like, hey, especially with anxiety, I'm saying, I'm your worst case scenario. Like, I have, and also anxiety, I had social anxiety, I have OCD, like I'm your worst case scenario. And do I look like a screw up, and with kids, they'll laugh and I'll be like, honestly, I don't look as cool as you do, or whatever. But still saying, this, I'm sitting here and I'm thriving. I love my life. right? Like I love the life that God's given me and that's around me. And so um,
Yep.
this is not, especially when I work with people of faith, of saying like your name, like your identity is beloved child of God. Like
Yes.
that is who you are. You know, if it's someone who's not someone of faith, of just being like, you are precious, you're an unrepeatable miracle. Like
Yep.
I'll even say, like, what does your name mean? Sometimes they're like, I don't know, my parents
Yes.
gave me like the name, whatever. And I'm like, this is what, like, this is who you
Yeah.
are. And there's so much behind that. And
Yep.
this is not minute. This is integrated. And the beauty of this, I think, in the redemptive part of our work is helping them say, this is so that you can be like me. Not all of our clients become
Right.
counselors. You know, I've probably had about like 6 to 7 who have become it through the
Oh,
process, which is so cool. But being able to say, you get to talk, not in an office necessarily, but in a coffee shop with a friend. And as they're noticing and saying these things, you get to help hold hope for them and
yeah.
help encourage them to do the really courageous thing you did. And
Yeah.
it's, but I think when we get stuck on the labels, we get stuck,
Yes.
right?
Yep.
And
Yep.
people are not likely to use the tools that they need to.
Hmm.
And they're going to say like, this is kind of a cop. I think it can sometimes be a cop out, you know, for
Yes. Absconding responsibility.
totally. And,
Yep.
and it's something
Yep.
where it's like,
Yep.
hey, this is, it's not your fault, but it is your responsibility, and helping them see
Yes.
steward this well and see how can you use this to actually create greater good in the world too.
Sure.
Yeah. How about
And I
you?
wonder, and that's what Schreier talked about, was like this weird identity formation that's
Yeah.
happening. And I don't even know that she was necessarily, I'm trying to remember that section. I don't know. Actually, I think it's on my bookshelf. Yeah, it's right over there.
Yeah.
I thought it was at this house
Love it.
or this my office.
Yeah.
But I think part of the identity formation is when almost like this thing that we're seeing with the therapy that's happened also culturally is the therapist creating identity that then they help create identity in the client, right? They're
Yeah.
cloning.
Yeah.
And I think that was part of her concern, is that by doing this, like she says, we're reinforcing the victim
Yes.
narratization, right?
Yes.
And where you and I are saying, no, our work is empowerment.
Yes.
We don't
Yes.
want little Emily and Pipers running around.
Yes.
We
Right.
don't want that.
Right.
We want that empowerment and that person to go out in that world and be
Totally.
able to hold hope for other people, because they know what it feels like to not have hope.
Totally. And I think
You
that
know?
it's hard because it can be very weationizing. I think with families, we live
Yeah.
in like such
Yes.
a culture, right? Where people can go to therapy and I mean, both of us, I think, really take this so seriously. But especially when we're working with a minor, I tell the parents, I'm like, I I believe I'm gonna have to answer to God for this, honestly. Like I
Yes.
take it very seriously, and I believe that your child, you are the best parent for this child. And so my job is to help um, heal if there's been tension and to help equip you guys so
Yeah.
that it's not being able for someone who goes to therapy or even in college and saying like my parents traumatized me and I'm cutting them off like
Yeah.
that. Yes, we need boundaries, not walls, right? So like
Yes.
sometimes if it's a really toxic or enmeshed relationship, you
Hmm.
need to be able to step back some, but it's being
Yeah.
able to learn how to be differentiated, not completely um you know disconnected. And so I
Yeah.
think, unfortunately, our when we do that and we over pathologize it, it also people are looking for, if they're victims, they're looking for a finger to point at, like who can I blame? And so not only are they helpless, but they're actually pushing away the support structures that
Yeah.
would be there to help them. I've seen I've seen where families will come in and say, "Hey, I'm so sorry. I was doing the best I could with what I knew." That's not an excuse, right? But
Yeah.
like
Yeah.
when parents can identify and say, "Oh, yeah, that actually was not helpful," saying paying you
Yeah.
for A's or pushing you to get on a roll when you're someone who's having like true ulcers at night and you're
Yeah.
your own worst enemy. Like, you know what? I was parenting out of my own childhood, like
Yeah.
you needed a carrot and you don't need a carrot. You don't need us, And so when
Mhm.
parents can come in a session and be able to do that healing work, it's
Mhm.
beautiful. It's life
It
changing,
is. Yeah.
right? But I think sometimes when we over pathologize it, it's like, okay, who broke you? who screwed you
Yes.
up, and now they have to pay.
Yes. The
Well,
revenge part. That's not part of therapy. That's not
totally.
what we do.
And
Yeah.
it just keeps you stuck, right? Like it
It
doesn't
does.
help to heal. And some people
Mhm.
do need to have, if there's very, again, unhealthy
Of
talk,
course. Yes. Yeah. We're not speaking
do that,
about.
right? But you also need to be able to see, okay, how can I engage with these people? Because it's not just your mom or your dad. There's other people in the world
Yeah.
that we can't cancel everyone, you know?
And it's interesting as you're talking that about the parents and the client. I would almost even kind of flip that over. If the clinician has not done their work, they are
Yes.
working through their
Yes.
childhood, whatever that
Yeah.
has not been healed. They're
Yes.
working it out on that client,
Yeah.
or they're avoiding it. And again, it becomes this identity formation around a thing that they've never actually done the work on.
Yeah.
With my mentees, I say to them, if you've not done therapy, you need to stop everything now and it's time to start.
Yeah.
Because
Yeah.
you have to look under all the rocks, especially the ones that are like, I want to work in trauma. I'm like, oh, okay.
Yeah.
Let's hold on a second, because we don't need you disassociating in the middle of
Yeah.
a session because you've
Well,
not done what you
right.
need to do.
Do you ask them? I'll often ask like why when I'm
all the time. And
when I'm
usually it's from a place of, well, I went through.
Yep.
And I'm like,
Yep.
okay, that's great. And that's a starting point, but you cannot go into this field if you've not worked your stuff out. It is unprofessional and it is clinically irresponsible. If you don't do your work. A gal interviewed me from her school a couple weeks ago, and she said, she was like, yeah, I'm what does she say? The word, I'm going to use the word smorgasbord of mental illness. And I was like, okay, tell me more about this. And again, she had like 15 diagnoses, which I was like, you need to go somewhere else. But she wanted to help people because she felt she was getting the help. But the more I talked to her, I said, honey, like, I think this is great, but please, here's a form to help you find a good therapist. These are the questions you need to ask, but you really need to do the work. And I think that's a real sign of a good therapist, that a therapist, I say to my clients all the time, what I'm putting you through is nothing that I've not been through.
Totally. Yeah.
I've been there. I've done it. I know this exposure therapy sucks. I've been there, but we're going to do it together, you know?
Yeah.
And they'll ask questions. I don't know how open you are with your clients, but I have clients say, well, did you kind of do this stuff? I'm like, heck yeah. This is terrible.
Yeah.
Or they'll ask about different anxiety attacks that I've had, and I'll full on share it with them, because it's like, I am a human being too. I've done the work. It's not always 100% of the time that I'm on top of it, because I'm human.
Right.
You know, but I know the tools too. But I think that's a biggie. We have to be careful with generalist therapists that aren't doing the work. I think schools need to do a much better job at gatekeeping this.
For us, we had to do MMPI-2s where I went to, and I'm so grateful they did. So for people who don't know what that is, it's really like screening for FBI, CIA, like making sure and finding out different pathology. And then we had to study our own MMPI-2s. But I thought that was
cool.
Really helpful. Yeah. And everyone had to go to therapy themselves. So like, even when I'm hiring people, I'm asking them, have you gone to therapy? Are you doing therapy currently? I know we'll talk later about questions to ask when you're, talking to different, who you're going to hire as a therapist. But I think it's totally valid and helpful to be like, hey, have you gone to therapy yourself? Because you're essentially saying like, have you done the courageous work that I'm about to do? You know what it's like feeling on the other side and sitting on this.
It's not enough to say you can kind of think about how it is on the other side. You need to experience it. And not everybody has stuff that needs actual in-depth therapy. And that's fantastic. You're going to be a great therapist. This is fantastic. But if you do have that deep work that hasn't been done, it will be expressed onto that client. And that is the last thing you want to do. So one of the other things Abigail Schreier talks about, you and I have talked about this, is that over-validation. Just as, the excessive like nodding and, I see, I hear there's no confrontation. And that is so not what psychotherapy was in the beginning. It was not.
Right. Oh. You're like a human trash can, right? Like,
yes. Like, oh my gosh. For validation. And I think part of it too, the class I was teaching the other day, one of the students raised their hand and said, are you pretty like abrupt with your clients? Like you kind of like seem like that, and the actual professor's laughing because she knows me very well.
I love it. I love it.
And when I said to him, I said, this is where the shift has happened. The whole point of psychotherapy is to confront the very thing that's causing distress.
Mm-hmm.
If all we do is sit there and validate every feeling, every single thought, therefore we're implicitly validating those behaviors that put you in this couch in the first place.
Yeah. And it's not scientific either.
No.
Being able to say like your brain, I do again a lot of psych ed, right? And us being able to say your brain is scanning for danger, right? Like we're not scanning for hugs, like our brains are in survival mode, we're scanning for danger. And so your brain is one heck of a communicator, but it can be a horrible and misaligned dictator, right? And so our feelings aren't facts. And so when we are validating all the feelings as if they're factual, we are adding to their pathology, right?
Yes.
So,
yes.
And if you're just doing that, especially with your trauma work, you're just affirming that the world is unsafe and adding to the trauma narrative, I'd imagine.
And I think I hear the argument against that is that, well, then you're denying their lived experience. And I said, I'm not denying their lived experience, but I am saying, can we take a second and not believe the feeling the second it happens, or the thought the second that it happens? Because again, if therapists knew the science and studied the brain, we know that there's misfiring. Like you can't, that doesn't work anymore. Mm-hmm. And I think too, what's happened is there was such a medical specialized focus in the beginning, right? Mm-hmm. That people got a bad taste in their mouth.
Yeah.
The psychiatric units and the drugs. And then we're hearing about all the testing. So it's this giant snap or like pendulum swing to this over affirming, this over validation, this, pathologization. I can't say it. You know what I'm trying to say.
Pathologizing.
Yeah. Thank you. I can't get the words out. But it's this huge pendulum swing. And I think what you and I are saying, hey, can we come into the middle a little bit? We're not saying over here's right or over here's right, but the pendulum has gone too far. And I think that's what Abigail Schreier was saying as well. It's gone too far.
Yeah. Yeah.
It's too far.
Totally. It's important of being able to understand your story, right? Like, and being able to see, where did you come from? How did this all impact? Like, that's part of our intake process. Understanding the gene frame and families, all of that, and being able to hold space and say like, we're not, the phrase hold space just drives me crazy sometimes.
Yeah, I know.
What the heck is that? But we are holding, we're saying, hey, let's talk about this. And then say, hey, is that really accurate? Because I think we're doing good work. We're able to see, hey, that was a thought. It was a form of, it's helped you survive.
Yeah.
Now we need to deconstruct that. But if we're being direct with it, they're going to hold on to these mindsets. They're going to hold on to these false mindsets and how they see themselves and others, and they're never going to get well. Right.
Yeah.
So, I think for us being able to like honor that and talk through it and say, how did this serve you? How did that help you? Survive? And we're going to call it out going forward. At the beginning, obviously we're not maybe as direct, but I would imagine you're the same way, where I'm like, where in the heck did you think that was a good idea? And they'll start laughing and I'm like, I don't know. It sounds to me like you wore the wrong lenses that day, and
right
about it. But they know where it comes from, but they don't just keep it there,
Well, and I think I hate the word holding space too, because it's been overused too much. But I think really what it is like I always say to my clients, we're not demonizing the anxiety or the effects of the anxiety or the trauma, but we need to hold it without participating with it, because that's how we can decipher, is what my brain is drumming up, is this true? Is this factual? And if the answer is no, then that's the empowerment of, oh, that means then it's not holding something true. I can therefore change and shift its focus. I can reframe, I can reteach the brain. And it's hard to teach people how to hold a distressing thought, feeling, behavior and not participate with it, whether it's shaming yourself, reenacting, whatever it may be. It is a hard skill to teach people. It's a very hard skill.
But I think when you can go back even in all, and this is not true forever, there are some, for sure, diagnoses where, I think of like schizophrenia,
Yeah. Oh,
other more severe diagnoses.
yeah.
But for what we're talking about, being able to say, hey, when you came into this world, you weren't, you weren't codependent. You weren't
Yeah.
having panic attacks. You weren't whatever. That was a learned behavior to
Yeah.
make it through and survive the system that you were in or the
Yeah.
situation you were
Yep.
in, right? And so
Yep.
you had to learn this, and now we're going to unlearn it. And
Yep.
I
Yep.
think that's helpful because we'll just talk about like a newborn, and they're not saying, "Oh, I'm sorry, I don't want to take up space." It's like all they are is need,
Yes.
and
Yeah.
being able to say, "You had that right," and then it changed, and so
Yeah.
we can go back to unlearning
Yep.
this. It just
Yep.
takes.
And I think that's the beautiful thing about counseling. And I think this is where I've seen the generalist drift. It's this kind of become the counselor is generalist because they're going to save everyone.
Mm.
Whereas as you and I are talking, the most exciting thing for me is I sit in here and just them verbalizing and learning tools. I'm like, I like, if I could see in your brain, I can see what you're doing. It's so life-giving and
Yeah.
exciting because we know, because of our in-depth research
Yeah.
and the science that we know of what we're doing, we are literally changing neural pathways by just giving them that couch to sit and learn. It's phenomenal, and I think that's the exciting part. Like, good therapy is having that excitement for that hurting person, because we know without a doubt you can get on this other side. We believe that, and these tools will get you there. You don't need me. You're going to learn these tools and you're out. I mean, it's just such a good, it's one of the most exciting things.
Yeah.
One of the most exciting things. They can sit there and they just feel a mess. And I'm in my head going, I know it hurts right now. I know, but keep going.
Yeah. I sometimes I have to stop. I remember I recognized because someone reflected back there, like, you're smiling. And I'm like, I'm so sorry.
Oh,
I just,
sorry. Yeah.
But even then I was like, I'm totally hearing you. And
Yeah.
I'm so excited because there's a map, right? Like, and
Yes.
I'm confident in the map. I'm not the map, right?
Yes.
Like, there's a process that people before us have done so much research and so much studies. And so it's like, I'm not Jesus,
Yep.
I'm not your savior.
Exactly.
We're going to use these tools because they work. And
Yeah.
I'm so excited because you're here.
Yeah.
And I am looking at the larger thing, and I'm here, and I'm just asking for you to like hold on to hope here.
Yeah. Yep.
Where a lot of I think of, have you seen Shrinking?
I love that show. Harrison Ford does such a good job in that show. I cry every episode.
He's so good. I yell every episode. My husband's like, stop talking, because I get onto, is it Jason? Is that
Yeah.
Siegel?
Yeah, Jimmy.
Jimmy, where he's like so enmeshed with his client. Like, that is bad therapy, right? Like, and that's why it's entertainment. Hopefully everyone knows that, right? But like, Jimmy at the beginning, like, he needed to work through his stuff. Like, he should never have been seeing clients. He's
never
working with prostitutes and doing cocaine, and his life's a mess and his family's a mess and all that kind of stuff. But, when we're good therapists, we've done our work, we've stepped back, we've in order to do no harm to them, we've done our work, and then we're able to engage and being able to say, here, it's about you, to where this Jimmy character, I think, is such a picture of bad therapy, where the character, I forgot what his name is, who lived in the back house, like his own client.
Oh yeah, it was his client, and let him live there. I was like, no.
But then is like at the kitchen table with his girlfriend now, and I know that he's now referred him out to a different therapist, but it's like still like so wrong. You can't be friends like that. But it's like now this person's just like integrated in his life, and that's so much about Jimmy and serving something for Jimmy, and that's why I think we have to be we have to really get over ourselves, right? And not get in our own way, where it's not about us. Like, we get to do this work with them, and we get to stand in this, like, I think, sacred ground of beholding like such beautiful change.
Yeah.
We're just a tool. We're just an instrument being used. And then they continue. And we aren't, our like self-worth is not caught up in it. Yes, it's rewarding, but like, it cannot be our identity, or we're, I think, more of a danger to our clients.
Absolutely. And speaking of Shrinking, are you in the third season? Because it started. It's so good. So I love what you're speaking of, because the Harrison Ford character, he's like the main guy at the practice,
Yes. Yeah.
and he has terrible Parkinson's. And you see him like, this is my identity. I have to do this. And then you slowly see him go, no, this is not my identity. I love what I do, but I need to release some of this control. It was a really good example, because Jimmy has been a mess the whole time.
Yeah. Yeah.
Or like the other therapist, I can't remember the gal's name in it. She screwed up in session.
Oh, totally.
She totally, and she's like, I'm sorry.
Yeah.
She totally apologized.
Yeah.
And that's a sign of a good therapist too, that says, whoa, I so screwed up. I screwed up with a client a while ago.
Yeah.
We were talking about events around here. And I said, yeah, it was like a bourbon tasting or something. And the client goes, you're saying this to an alcoholic. I was like, oh, I just felt like such an ass.
Yeah.
And I came back next session. I said, I really want to apologize to you. It was not on purpose. I wasn't trying to be painful or do anything wrong, but gosh, that was so insensitive of me. And as therapists, we have to be able to apologize and say, I screwed up so bad. Please forgive this process. Yes. I am human.
Yes. Yeah.
You know?
Yeah. Absolutely.
Well, this has been fun. So let's kind of bullet point good characteristics of good therapy, core characteristics. And if anybody has questions, we're just kind of riffing this. We've got like an outline. We hope that this helps some of you understand the idea of good therapy. Again, this is a 3-part series, so we're going to work on it. Some core characteristics of good therapy is clear diagnosis or a working formulation. Super important to have. The treatment matches the condition. If they're like, oh, we're just going to sit here and talk, I would maybe go elsewhere. Define goals and treatment plans. We didn't talk about that a lot, but really key to good therapy, right? Because you are going to just drift into the affirmational validation kind of stuff if you don't have that. Skill acquisition, not just insight. Those educational tools, right? Like insight's great, but insight's only the very, very beginning. We have so much after that. Measurable progress. Emily and I believe very strongly in data-driven care, because again, the good thing about using assessments like your Y box and the others that I use is that it keeps us out of assuming that we're doing a good job. Yeah. And we can see, am I doing a good job? And am I not doing a good job? It really keeps us actually accountable to the goals, not to our internal biases of, oh, I'm an awesome therapist.
Yeah, exactly.
Transparency about their approach. That's good. Ask them direct questions. You have to ask direct questions. Movement toward independence. We talked about that. Saying goodbye is hard, but we love doing it. And then time limited when appropriate. It doesn't always have to be long-term. That's not something that we always have to do. Anything you want to add to that? What do you think?
No, I think that some of the things that we've seen is just, really giving them support is helpful, but without a strategy, it's not treatment, it's not therapy. It's listening, and friends do that, community do that. And another thing that is kind of taken from the Bad Therapy book is good therapy builds resilience, not fragility. And so you need to feel empowered, knowing this is not lifelong. I'm being able to learn these tools. I'm improving, and I'm able to walk into this world and help others, hopefully too, in some way. But I'm not stuck. I'm not fragile. I'm not labeled, and I'm not a victim that's living.
Yes. Yeah. And we've put together a list of questions to help everybody, to help you find good therapy, because we understand that this is just one singular podcast, but we really do want you all to have, you're ready for these consultations. Most therapists provide at least a 15-minute free consultation. So just pull out the sheet and ask the questions, you know. So we've created that for you all. You can download that on our individual sites. We'll have it in the show notes. So this is just hopefully another tool for you all to find good therapy. We are going to continue this series. So session 2, we are really going to talk about people that are currently in therapy and they feel maybe they're stuck and they're not quite sure what to do. So we'll speak to that. And then I don't even think we got through our whole outline today, but that's okay. We've talked about a lot of stuff.
Okay.
And then the third one, we're actually going to talk to those of you that think therapy is a bunch of crap, because we know you're out there too, and we understand why you feel that way. So we're going to speak specifically to you as well. So we hope that everybody's going to stick around. Emily and I are having fun with this series, and really hope that clinicians in the world understand that we're not trying to speak against you. We're really just trying to raise the standard of clinical practice, because the pendulum swing has just gone way too far, and we've got to reset course and really empower these clients that so desperately need the change.
Yeah, we want to do better. Yeah. We want to help you guys more.
Yeah, that's it. All right, y'all. We'll see you next time. Thanks for joining us.
Thank you.
That brings us to the end of this episode. Thanks for joining me. I hope you learned some tools that can equip you to untangle your mind and untangle your life. If you're curious about working with me for your anxiety or trauma, head on over to my website at untangledmind.net to connect with me. If you enjoyed the show, please rate and review me on your podcast listening platform and share it with your friends and family. As always, thanks so much for listening to me, Piper Harris, with the Untangled Mind podcast. I'll talk with you next time.